Thank you for the very kind invitation to be here today, and I'd particularly like to thank Karen and the organising committee for their hard work and the amazing turnout that we have today. It doesn't seem that long ago that I was speaking in Sydney 2 years ago, and at that stage growth hormone for children in Australia had recently been approved, and I've just been looking at the statistics, and it represents now almost 10% of the growth hormone budget for Australia, which I think is really impressive, suggesting that probably all the children in Australia are getting growth hormone now who are Prader-Willi syndrome, which is a superb achievement and something that we're still trying to get in New Zealand. We've got most of ours on growth hormone, but possibly not all of them yet. I also didn't realise and this is my fault, no one else's, that Ellie's talking about infants with growth hormone after me, and I think of children as infants as well, so I've added both in, but I will go over the infant stuff quite quickly because Ellie will probably do the same thing as me. So, we know what Prader-Willi syndrome is about. The parents here and the specialists who are here understand that it's a complex set of issues. And those are not all of them. It's not an inclusive list, and we've just gone through them with John. And I'm going to really focus on the endocrine today, but that will also involve some aspects of obesity and neurodevelopmental effects, although, as I said, Ellie will be talking more about that than I will be. If we look at the endocrine issues, I'm going to be focusing on those associated with growth hormone. In particular, that reflects short stature, of which virtually all PWS children and adults have. Those who don't get growth hormone, at least that is. They also have abnormal body composition. So for any given BMI, they have more fat and less muscle than a normal person. So even if you have a normal BMI, you will have a lot more fat than you would get in a child who doesn't have PWS. On top of that, these children don't go into puberty normally. Most of them have delayed puberty or don't enter puberty, and if you don't have male hormone or female hormone around, you have issues in later life. Paradoxically, there's a small group who go to puberty way too early, so it's one or the other. So there's issues there, and the boys often don't have their testicles coming down, which is cryptorchidism. Because sex steroids are so important for bones, you get reduced bone density and increased risk of fractures. You also need muscles pulling on bone for it to work properly, and high fat mass also can cause problems with your bone. So for a number of reasons, your bone mass is reduced and fractures are much more common. Diabetes is type 2 diabetes, and it only occurs in those who get obese. So this is an issue for those on the severe end of the spectrum. And in fact, children with PWS actually respond to insulin better than normal people. So you have to be a lot fatter to get type 2 diabetes than you do normally. But it's still an issue, obviously, because some of the children with PWS get very overweight. And the whole background for all of these things is abnormalities in a part of the brain called the hypothalamus, which affects the pituitary gland, which is where many of your hormones are made. And this can also affect not only growth hormone, which we'll talk about in a second, but also your adrenal function and your thyroid function, and that has implications for a smaller number of PWS patients, but it can at times be life-threatening and needs assessment. Again, that's outside what I can talk about today in the short time I have. So let's start on short stature. Men and women with PWS are about 15 to 20 centimetres shorter than they should be. Okay, so boys are a bit under 160 centimetres and the women are a little under 150 centimetres. And their growth pattern is always short all the way through, although they tend to lose more height during puberty because they often don't have puberty, and that's when most of us get an extra 30 centimetres. So if you don't have the sex steroids, you end up even shorter than you otherwise would be. But they're short right the way from birth. Excuse me. Now, one of the things we know about PWS is that it's associated with a low insulin-like growth factor 1 or IGF-1 level. Now, what on earth is that for most of you probably saying? Growth hormone is very hard to measure in the blood because it only lasts for a very short period of time. So measuring growth hormone levels doesn't help you work out whether you have a growth hormone problem. But IGF-1 is what growth hormone stimulates, mainly in your liver, and it lasts for days. So you can actually get a really good understanding of what happens to growth hormone by measuring IGF-1 levels. And we know they're low in PWS, suggesting there's a growth hormone problem, a secretion problem in the pituitary gland. On top of that, that body composition problem of lower muscle mass and higher fat mass is what you see in growth hormone deficient children. So again, suggesting there's a problem with growth hormone secretion in PWS patients. And because of this, and because we know there's a hypothalamic problem with the kids with PWS in terms of eating, satiety turning off, and temperature control, etc., the suggestion was made, well, okay, maybe they have a problem with growth hormone secretion. Excuse me. As a consequence, in the early 90s, growth hormone was started to be used. I'm sorry, I'm just getting over a bug. Typical, isn't it? What we found, though, what these studies found is that there was quite marked improvements in growth velocity, very similar to what you'd see in someone who had growth hormone deficiency. Thank you. On top of that, on top of that, they also showed that these patients, these children who are getting growth hormone, had changes in body composition in a way that you see happening when you have growth hormone deficiency, in that they put on more muscle mass and they lost fat mass. However, unlike the kids with growth hormone deficiency, it did not normalize. It was dose dependent, and you had to use pharmacological doses of growth hormone to achieve them. So there's a number of studies done. I just want to put up the ones by Carell's group, which were the initial ones, and I think the most elegant ones. And I'm just going to see if this will work. It does work. Fantastic. So this is quite a complicated paradigm. Let me take you through it. For the first 12 months of the study, he had 35 growth hormone patients who got growth hormone, or Prader-Willi patients who got growth hormone, 19 PWS patients who didn't get growth hormone, who acted as a control. For the next year, oops, that's what I was worried about. For the next year, all of them got growth hormone, and this is all at a dose of 1 milligram per meter squared per day, which is what most of the world uses. They use a slightly lower dose in Australia currently. In the next 2 years, they're split into 3 groups. One group got a bigger dose, 1.5 units per milligrams per meter squared. One group continued at 1, and the other group reduced down to 0.3, so quite a low dose. But not that far off what they start in Australia. Australia starts close to 0.4, 0.5, but still on the lower side. So what do they show? Well, if you look at lean mass, which is basically muscle mass, you can see over that first year, and this is in kilograms of lean mass, the group that got no growth hormone put on a little bit of muscle, but not nearly as much as normal children do. So I'm doing it again, sorry. The group that got growth hormone put on about 5 kilograms of muscle mass, which was very similar to what normal children do. Normal children put on a little less than that, so it was almost catch-up growth. Over the next year, they continued to put on the same amount of muscle mass and it continued all the way out for the 4-year period. And increasing the dose of growth hormone made no difference. So 1 milligram per meter squared per day or 1.5, they both put on a similar amount of muscle mass, okay? But if you reduce the dose down to 0.3, that effect disappeared or was quite attenuated, suggesting that you needed around 1 milligram per meter squared per day of growth hormone to actually get the effects on muscle mass. So what about the effects on fat mass? Okay, so this is fat mass in percentage on the y-axis here, and you can see all these kids are quite fat. They've got body fat around 40 to 50%, kind of high 40s. If you don't get growth hormone in that first year, your fat mass goes up a little bit. But if you get growth hormone, you get quite a very impressive marked reduction in fat mass, so that lipolytic effect of growth hormone reducing your fat mass. Over the next 12 months, there was no further loss, and it stayed about the same. And subsequently, those who stayed on 1 milligram had a slight increase in the amount of fat they had over that time, whereas those who had the higher dose actually went down a little bit and then maintained it at a slightly lower level, whereas those who had the low growth hormone dose really lost the effect. So fat mass needs more growth hormone if you want to see an effect. But there's a problem with that. If you use bigger doses, and this dose was at 1 milligram per meter squared per day, and I just want you to focus on the top line there, the IGF standard deviation score. Now, for those of you who aren't statisticians, and I'm assuming most of you aren't statisticians, a standard deviation score is a way of comparing everybody of different ages and different genders, male and female that is, at the same. And so 0 is the average for everybody, with a range of +2 to -2, which is 95% of the population. So anything over +2 standard deviations is considered excessive, and anything below -2 is considered low, okay? And you can see here that these kids started off with low IGF-1s, almost 2 standard deviations below the mean. They had low IGF-1s. But after 1 year, they had very high IGF-1 levels. Over half of them were above 2. And at 4 years, it was the same. So this is on 1 milligram per meter squared per day. And the importance of this is if you have a growth hormone tumor, so you're a person who has making growth hormone continuously year after year after year, and usually that takes 10 to 20 years to diagnose. Those people have higher rates of early death from cardiovascular disease, much higher rates of malignancy, bowel cancer, prostate cancer, breast cancer, etc. High IGF-1 levels probably promote malignancy over decades, and the concern is if you're going to give a child really high IGF-1 levels for many, many years, it may not be a good thing. And the current suggestion, and we don't have proof about this, this is just based on first principles, the current suggestion is to try and keep them under 2 standard deviations. And at the moment, that 1 milligram per meter squared dose may be slightly too high. So moving on from that, and using that same 1 milligram per meter squared dose, what happens long term? What happens over 8 years rather than just the first 4 years, 3-4 years? And there's a really nice Dutch study looking at one of the largest groups of PWS patients, which has shown that in recent times. So again, I've got quite a complicated graph here, so I'll just, so it's hard to do it without a thing. So the first one, an A is your lean body mass, standard deviation score. So again, it's converted to the standard deviation score, 0 being the average for normal kids of different ages, at any age, and +2 to -2 in those dotted dashed lines here. And you can see that over the first 2 years, you get an increase in your lean body mass, the muscle mass you have. And then it stabilizes, it stays pretty constant for the next 8 years. Now, you will recall that last graph I showed you showed the lean mass continuing to increase. But that's because it was measuring kilograms. It wasn't a standard deviation score. Every year that goes by, every normal child is putting on 3 or 4 kilograms of muscle. So the fact that it's staying the same suggests all these kids are putting on that muscle every year, okay? And that's a good thing. So compared to normal kids, what you've done with growth hormone is they've become normal. They're putting on the same amount of muscle that every other child is putting on. They haven't quite reached the average, but they're maintaining it. They're not falling away. Whereas the PWSs down here who don't get growth hormone, they go down like this over time, okay? So we've actually maintained their muscle mass in the normal range, albeit a little below the average. If we look at fat mass, we've got to look at fat mass, which is B, fat mass standard deviation score, versus BMI, and BMI for normal kids and BMI for PWS kids. The point I want to make here is that all the kids in this study were well controlled from a diet perspective. They were lean. You can look at their BMI for PWS is below average, and their BMI for normal kids is only just a bit above average, but in the normal range. But despite that, their fat mass is high. And this is what I was telling about before. For a given BMI, PWS children are fatter than you expect. And you can see initially with growth hormone, you get a loss in that fat mass, but over time, it sort of stays the same. So you don't get a change in your BMI standard deviation score for fat mass, but at least it doesn't go up. For those of you who are interested in height, you can see that you get normalization of height within 4 years. So these kids were short, but within 4 years, they're the same height as other children of their age. So it takes about 4 years to normalize height. Then after that, their height stays the same. And this is what you see with growth hormone deficiency. Giving growth hormone doesn't make you taller and taller and taller and taller. What it does is it brings your height up to the height you would be normally for your parents' heights. And then you grow along that line, parallel to it. And that's exactly what these kids are doing. So within 4 years, you can normalize their height. And if they continue on with growth hormone, they'll be the same height you'd have expected based on their parents' heights. But as I said to you, unfortunately, what we're also seeing is that IGF-1 level is staying around 2 standard deviations on average. So these are quite high IGF-1 levels, and there is some concern about the safety of that long term. So to summarize this part of the talk, growth hormone therapy leads to normalization of height if started early enough. If you start at 11, 12, 13, you're going to get increased growth, but you're not going to normalize it. If you start in infancy or early childhood, these children are normal height, and I've seen many PWS children over 6 foot, over 180, 84, 85 centimeters, basically the same height as their parents. It has a positive effect on muscle mass, increases muscle mass, it reduces lean mass, but you need bigger doses of growth hormone. As a consequence, you often get high levels of IGF-1 level, and that may, and only may, be a negative factor long term, and monitoring that's probably very important as part of the process, and something we're trying to bring in Australia currently on a more regular basis. Now, I'm going to skip over this a little bit because I think, Ellie, you're going to talk to this, right? Yep, I see a nod. All right. You're talking about a cognition, and you're not talking about cognition? Okay, I won't skip over it then. Okay. Can growth hormone make a difference to your brain development? Which sounds bizarre, I know, because growth hormone makes you grow, right, and changes fat and muscle. But there were some initial studies done in the late 2000s. This one, 2007, was one of the first, looking at PWS subjects, and they used 2 years, what we consider a standard dose of around 1 milligram per meter squared per day for the first year, and the second year a little higher. And what they found is that, as you'd expect, these kids grew better, they got more muscle, they had less fat. But when they did some IQ testing, they showed that their language and cognitive scores improved over that time, over the first year and the second year. And interestingly, after that first year, the PWS subjects who were treated before 12 months of age spoke their first words earlier than the others and walked earlier. And if we look at the slightly complicated diagram here, I'll take you through. The mobility percentiles are 50th percentiles average, and obviously 100th percentiles markedly advanced, and 0 you're quite delayed. You can see here that at baseline, 2.6 percentile, 6.4 percentile, these PWS kids are not at the bottom end of the normal range, okay? But if with growth hormone, it increases it, and that continues up both mobility and stability percentiles. So you're getting a positive effect of growth hormone on their mobility and on the stability. If you look at their language and cognitive Z scores, their Z score is another way of saying standard deviation score. So 0 is average, +2 is markedly advanced, -2 is significantly delayed. You can see that these kids are significantly delayed both in terms of development and cognition, but with growth hormone, it gets it close to 0. You're getting improvement. So growth hormone doesn't normalize things, but you're certainly seeing improvements in infancy with cognition. And a similar study a year later showed it in a different way, and this looks at the difference between 0 and 1 year of growth hormone, and half the group were randomized to growth hormone, half didn't get growth hormone. And you can see 0 is no change, and you can see the group that got growth hormone had an improvement in mental development and an improvement in motor development. And in fact, there seemed to be a worsening in motor development over that time. Again, suggesting that growth hormone may have some beneficial effects in infancy on cognition and motor development. And indeed, in the same study, they looked at those PWSs who were more delayed versus those who are more advanced, and those who are more delayed got a greater benefit. So again, there may be maybe greater benefit for those who are a bit more delayed early on for getting growth hormone, and maybe they've got more severe hypothalamic dysfunction and make less growth hormone or have other issues. But, and as I say, there's a small study, it has not been replicated yet, but it's quite interesting data. Finally, in this area, there's been a recent study published in December last year looking at the effect of physical training and growth hormone. Now, it took doctors 40 years to realize that this is proving it, that male hormone makes athletes stronger and faster, even though the Eastern European countries and probably America and other places were using it for years. It took us 40 years to prove this. And it took a long time, in part because it's a combination. You've got to train as well as have the drug. The drug on its own is not enough, okay? And that's probably true for growth hormone too. So if you look at what's happened, this is a group of just over 20 infants. Half of them are randomized to growth hormone, half of them not. And they measured muscle thickness, muscle strength, and motor performance as outcomes. But they trained them they did some physical training, a physiotherapy mediated approach, training them from about 13 months of age, and about 5 months later they started growth hormone. Okay, and a standard dose of around 1 milligram per meter squared per day. So what did they show? Well, not surprisingly, they showed on the ultrasound scans of your muscles, and they looked at 4 different muscle groups. They're all smaller than they should be. They're all thinner than they should be. You give them growth hormone, those muscles get bigger. And the muscles get bigger, and there's an association between the muscle size, the cross-sectional area, and strength. So the bigger the muscles, the stronger they are. But what they also showed is that there was an independent effect of physical therapy. So you gave them physical therapy, you magnified the effects of growth hormone. So if you're going to use something like growth hormone, you should always involve a physical training program, and the more physical training, probably the better they'll do. In terms of this study, they looked at motor scale performance. You may not be able to see this that well, but along the bottom axis here, the x-axis, you've got age in months up to 60 months, 5 years of age. On the y-axis, you've got the developmental age motor development. It goes up to 18 months. This grey line here is what happens normally. Okay, so 18 months up here 18 months up here equals to 18 months down here. So that's the trouble. So the grey line represents normal. The black line represents PWS not on growth hormone, but getting physical therapy. So you can see that at 5 months of age, the PWSs are about a few months behind, but as they get older, by 35 months, 36 months of age, they're about 18 months behind. And if we look at the time they started growth hormone, at about 18 months, they are about 9 months for a normal child. So they're quite delayed. But the longer you go, the further delayed they get. This distance gets worse with age. Okay, they're on a different trajectory. Once you start growth hormone, you improve their motor development, not dramatically, and so they're still delayed, but you still improve it. The question, of course, is if you started growth hormone not at 17 months, but back here at 5 months or 6 months, and you start to go up here like that, you may actually get much better outcome long term. And that data, that needs to be done, hasn't been done yet. But it's really suggestive that earlier starting may make a difference to outcomes. And if we look at this, we've got a study done a few years ago now looking at 29 subjects with PWS, and they all treated them, they were between 4 to 37 months of age, and they treated them with growth hormone, and then they split them into those who had it before 18 months and after 18 months, and they showed those who got it after 18 months really didn't get much change in their mobility scores, but those who were treated before 18 months got a lot more improvement, again suggesting that earlier treatment may be the way to go. There was a big consensus meeting, and I can give anybody who wants it this paper, but it's a PDF. But it was a European, Canadian, American group who put out a consensus statement in 2013. And in terms of initiation, they did say that you saw benefits starting at 6 months of age. They made the comment that some units are now using starting at 3 to 4 months of age. But in the end, they couldn't actually reach consensus as to whether that was actually a good thing or not. And that just, I think, reflects the issues around the group in question. And the Canadians in particular are quite conservative about using growth hormone. But there does seem to be some benefit there. What dose should be used? As I said to you, that 1 milligram per meter squared per day dose, which is what's used traditionally in literature, may be a little too high if you look at IGF-1 levels. And so, again, just on the expert recommendations, the same group suggested starting at 0.5 and then based on your IGF-1 levels working up towards 1. In New Zealand, we start at 1 and work our way down. In Australia, you do it the other way around. You start lower and work your way up. So I'm not sure what the best way of doing that is, but measuring the IGF-1 levels, I think, is the important point. And finally, for the last few minutes, is growth hormone therapy dangerous? The bottom line is I don't believe it is. There's been work done on this for many, many years. And it's been one of the most extensively studied therapies. A lot of suggestions have been made and a range of issues have been associated, but none of them are causal. So the bottom line is I don't believe there's any evidence, and I don't have time to go through these in detail, but I'm happy to talk about it later. In terms of PWS, there was an initial concern that growth hormone was associated with early death, and that was thought to be maybe related to breathing abnormalities on growth hormone. It subsequently was shown that all PWS kids were having problems with early death, and that hadn't really been recognised before, and it wasn't a growth hormone-mediated event. Growth hormone, however, will make type 2 diabetes worse and can put you into type 2 diabetes if you're very overweight, so you've got to be careful. It can make scoliosis worse, although it's probably going to get worse anyway, you're just growing faster. And really, in terms of cancer risk, there's no evidence that's the case, but it's probably sensible to keep your IGF-1 levels below 2 standard deviations above the mean. Gillian Dix is going to talk about this afternoon, so I don't want to go into sleep abnormalities in any detail, but the bottom line here is that you do get some sleep disturbance with PWS. In particular, it causes your lymphoid tissue, your tonsils and adenoids to get bigger, and that can cause obstruction, particularly during sleep. And so getting a sleep study on all kids, whether you're on PWS or not, but early in life is sensible, but also getting an ear, nose and throat specialist to have a look, and if necessary, take out the tonsils and adenoids is sensible. It's also suggested you get them repeated every year while you're on growth hormone in case there are problems. But in general, growth hormone seems to improve the central drive for sleep, so what they call a central apnea. Apnea is when you stop breathing. Your growth hormone seems to improve that, but it can cause increased obstruction, and so you've just got to be careful about that. But in general, it seems to be safe and actually improves respiratory drive long term. There are a number of exclusion criteria that were put out by the consensus meeting, and I'd agree with all of these. You shouldn't start growth hormone if you've got severe and progressive obesity. In other words, their diet's not controlled. Growth hormone is not going to help if you can't do the basics. So unless you've got your child's nutrition sorted, and that can be really hard, but unless that's sorted, there's no point trying to modify things at a lower level, because it's just not going to help. It can also drive them into diabetes. If you're obese and you get growth hormone, it can make you get diabetes, which is the last thing you need. It can also, if you're also overweight, you're more likely to get sleep apnea, and hitting growth hormone and make obstruction worse. So again, you should avoid it there. I think if you've got cancer, clearly it's a good reason not to have growth hormone, and we wouldn't put that on a normal person. The last one they put down, the active psychosis, is an interesting one. There is no evidence that growth hormone makes any difference to psychosis. But I guess if you've got psychosis, you've got other issues dealing with, you want to deal with those before you think about any other sort of therapy. So that would make sense. But actually, growth hormone does not have any beneficial or negative effect on psychosis. So in conclusion, initiating treatment in infancy seems to be beneficial on body composition, strength, growth, and motor and cognitive development. There is some evidence suggesting starting in infancy is more beneficial than starting later, but you get beneficial effects at any time point you start. And in general, it seems to be very safe in PWS, but long-term consequences of very high IGF-1 levels for many years remains a little less clear, and that's something we need to watch, I think, very closely. And on that, I'd like to say thank you, and I'm very open to questions.